Okay, thanks very much. So I'm Steve Nicholas. I'm going to talk about the next section, talking about shoulder instability management and return to play guidelines. We're going to know the anatomy and pathoanatomy, treatment algorithms, and certainly criteria for return to play, and some of the things we use to decide whether or not someone can play in season or whether they need to go and have surgery. So certainly, shoulder instability has been around for a long time. These diagrams showing somebody doing a Coker maneuver in ancient drawings. So it's certainly been a problem for a long time. And Hippocrates, a Greek, one of the first sports medicine surgeons of all time, really discussed the fact that it's important to understand how to manage these patients with shoulder instability, because the Olympics and the competitions they did back then, those athletes were not able to return to play or return to function because of this significant problem. So it causes a significant disability in patients. And we know that these patients, when they do try and come back, frequently have a high incidence of recurrence. So what is our approach? Well, certainly, before we go on, we have to understand a little bit about the anatomy of the shoulder. So just looking at the anatomy of the shoulder, we understand that this is a very intrinsically unstable joint. It's like the ball on a tee. So very few, less than 1/3 of the humeral head articulates with the glenoid during any time. So there's very little bony support. And then there's other things that occur to enhance this bony support. The labrum deepens the bony glenoid. It acts as an anchor for the ligaments around the shoulder and helps to increase the surface area and actually helps to improve our stability. The labrum is composed of, the labrum then attaches the ligaments to it, and it's composed of the anatomy of the inferior glenohumeral ligament. And you have to think of this as a pouch. The anterior band and the posterior band are connected by the intervening capsule, and this acts as a hammock. So you internally and externally rotate the joint. With external rotation, the anterior band tightens up, preventing anterior translation. With internal rotation, the posterior band tightens up and prevents posterior translation. So the shoulder stabilizers, the shoulders has the most motion of any joint and rely not only on the dynamic stabilizers, but the static restraints. So I tell patients all the time, when you tear your shoulder, when you tear your labrum, you've now damaged your static stabilizers. We can actually fix that, or we can stabilize it by improving your dynamic stabilizers. And that's what we're trying to do when we conservatively manage these shoulder instability patients. So we begin to think of the shoulder in different ways. The static factors, articular congruence, articular version, the glenoid labrum and capsule ligaments, versus the dynamic factors, the rotator cuff, the biceps tendon, negative interarticular pressure, and scapulothoracic motion. And I think we need to understand scapulothoracic motion and examine it in the office. A lot of what we do and apply, the therapists have a great opportunity to manage. What I was thinking about with the question previously asked before about ACL and return to function, patients coming to 6 months post-op, and we give them the jiggle test. They see the doctor does a Lockman, jiggles the knee, says, okay, it's 6 months, you can return to play. There's no criteria we have to evaluate that. What we do in our office, we'll grossly evaluate seated hip flexion as a great evaluation of their limb strength. We'll actually do a single leg hop to see if they're landing on their heel and they're able to resist the shear forces that are required of a single leg hop. Well, the same thing with the shoulder. We have to think about the scapulothoracic joint in addition to the glenohumeral joint. And think of the scapulothoracic joint as a seal with a ball underneath it. And the seal is always trying to adjust to balance the ball. Well, the scapulothoracic joint has to set the base for the shoulder to be balanced on. And so we need to address scapulothoracic strength and dyskinesis in addition to the glenohumeral joint. I don't want to go too much through the anatomy. We know negative intra-articular pressure, but again, pathoanatomy, capsule, Bankart lesions, capsular stretching, capsular laxity, and wide rotator interval can cause instability. The glenoid with a bony fracture or a plastic glenoid or a glenoid fracture can cause instability. A labrum with a Bankart tear, both anterior, posterior tears, and supralabral tears, and problems with the humerus, tear of the insertion of the capsule on the humeral side, and rotator cuff problems can also cause instability in these patients. So let's talk a little about glenohumeral instability. About 2% incidence of glenohumeral instability over a lifetime, and anterior dislocations account for 95% of those. Athletes, 25 years and under are the most commonly affected, with males more common than females. And a Bankart lesion, an avulsion of the inferior glenohumeral ligament, occurs about 85% of the time. The most common mechanism of injury is a fall in an outstretched arm, or, as happened to many running backs, lying down, the lineman runs up, extends the arm with slight external rotation, and the shoulder pops out. So we have to understand the direction of the instability, whether these patients have inferior instability, anterior instability, or posterior instability, to make determinations as to whether these patients can return to play. We've all seen offensive and defensive linemen that have significant posterior instability lesions that really are not that disabled, that they can play from some adjustments, sometimes with a brace, play the season, and we can fix them after the season. But let's look at the decision-making process that we go through when we decide whether somebody's going to return to play, or whether they're going to have surgery, or what we're going to do. Well, age is certainly the single most important factor predicting recurrent instability. So a first-time dislocator versus a recurrent unstable patient, whether or not we stabilize them immediately is controversial. Certainly in our hands, we believe that patients who have an unstable shoulder and have an acute anatomic disruption are best managed by fixing them immediately. Patients who undergo an instability episode and are not fixed usually undergo 3 to 4 months of therapy to come back to play and do things in the future and try and decrease the chance of recurrence. That recurrence rate can be about 50%. In our hands, we feel that putting the labrum back to where it goes immediately gives us our best chance of avoiding surgery. But now, you have athletes, and it changes things a little bit. Particularly, I think, it's more likely to be controversial in the high school athlete than in the professional athlete. Professional athlete, you're going to see them, you're going to make accommodations because they have long careers. They're very aware of the fact that any disability they might have, if they don't fix right away, might impact their career in a longer way. So we have to consider these contact athletes and athletes in general in a different realm. So let's talk about the contact athletes. So they're particularly prone to anterior instability. We can decide between open and arthroscopic techniques, or whether it's fixed the first time or later. We don't really, we'll go through that in just a moment. You have to recognize where the instability is, imaging, x-rays, make sure there's no fractures or a plastic glenoid before you make a decision about how you're going to treat these patients. Your trainers, a lot of people here are athletic trainers, physical therapists. You have a patient with a dislocated shoulder. How do we reduce that dislocated shoulder? Well, the Hippocratic method, when you're by your side, when you grab the patient's arm, you grab the arm, put your foot in the armpit, and pull on the arm. That's when we reduce it. Difficult sometimes. I think the one I prefer is a Stimson maneuver, where we actually hang weights on the patient's arm, put them prone on the table, usually write your note, or you'll sit in the training room for about 10 minutes, and these patients reduce on their own. It's important that we understand how to reduce this. The story I'll tell is I was at a Jet game covering the sidelines, and the referee went down and dislocated his shoulder. The referee's about 56 years old, so you have to think about fractures, one of the things that occur with this dislocation. So we were the home team, so our job is to take care of the ref. So I ran out to take care of the ref, and I grabbed his shoulder, and I felt a crepitation as soon as I tried to pop it back in. But the guy from the other sidelines is the guy who trained me. So he laid down next to the official, and he pushed me out of the way. He said, "I got this." So he grabs the guy's shoulder, and he's like grinding it, trying to pop it back in. Didn't come back in, so we went to the locker room. We took an x-ray, and the patient had a 4-part fracture dislocation of the shoulder, which was probably a 1-part fracture dislocation before we started pulling on it so hard. So the doctor said, "Look, I'll fix the shoulder," and the official said to me, "I'd actually like him to fix my shoulder because it hurt a lot more when you were trying to pop it back in." So we should be aware when we're doing these techniques. You know, it should take some experience to reduce them on the sidelines. You have to be aware if you feel any crepitation to stop, because you don't make a fracture worse. But certainly a well-trained healthcare professional on the sidelines can make the attempt to reduce the shoulder. We had a situation about 4 or 5 weeks ago. I was at a game. A kid who was playing for us dislocated his shoulder, tried to pop it back in on the field, could not pop it back in the field, brought him in the locker room, laid him on his stomach. His parents were there freaking out, just hung the weight, we're just talking. He says, oh, my shoulder just popped back in. So there's ways to do this without violently trying to reduce the shoulder. So let's go through the decision-making a little bit. Pascal Boileau has described his way of approaching patients with instability, and he calls this the ISIS index. ISIS has taken on a whole new term, and this was not in existence when he actually wrote this index, but what he does is looked at a number of different factors and decides what the important factors are to determine whether someone should undergo an arthroscopic procedure or some type of open procedure. And in Pascal Boileau's evaluation, he looks at the age of surgery, patients under 20 years old versus over 20 years old. Patients under 20 years old at the time of injury are afforded 2 points. Whether they participate in competitive sports or recreational sports, again, 2 points assigned to the patient. Whether it's a contact or forced overhead activity or something that's non-contact, there's 1 point. Whether the patient has hyperlaxity, 1 point. Hill-Sachs lesion or defect in the bone seen on X-ray, 2 points. And loss of glenoid normal anatomy, again, assigned 2 points. So the total score is then determined from these multiple factors. And it's important to understand here what you're looking at. Age, bony conformity, hyperlaxity, contact sports. These are all the factors we use to determine how we should treat the athlete. So let's look at the algorithm for events that occur. So in-season instability events. First of all, you can reduce them, you obtain x-rays to find out if there's any bony lesion. Bony lesions over here are going to throw you into the immediate surgical care realm, because those things need to be fixed right away. You're going to get in trouble. So let's look at the patients who have an initial instability but do not have a bony lesion. And what are the considerations we have? Well, this is why I say in the professional athlete, it's different than the high school athlete. Because the professional athlete, no matter when he gets it, is probably going to have it fixed, because we're worrying about a long-term contract. But when you're dealing with a high school athlete who's worked his whole life to be a football star and go home with the cheerleaders, and now it's the third or fourth week of the season, is his senior year, he's never going to play football again, and he dislocates his shoulder. How do we approach that? And can we allow them to play? Well, we used to say, look, shut him down, too much risk of putting him back in the game, but there are mitigating factors. Senior year, toward the end, middle of the season, there are a couple more games left. You can actually immobilize these patients. We used to immobilize for a full month before we let them go back to play, but then we found out the period of mobilization didn't affect the recurrence of instability. So now what we're doing is we get them moving pretty quickly in an accelerated rehab program, and when you make the decision to let them play, you can probably get them back in a couple of weeks, allow these patients to then finish their season, and after the season is done, you can fix them subsequently. So I'll talk to Lyle about his approach, because Lyle takes care of Alabama and takes care of a number of professional athletes, and certainly high school athlete, I think, is in a different approach than these patients. One study done on NCAA athletes looked at patients who had returned to play in season after an anterior shoulder instability. 73% of those patients were able to return to the sport with a median of 5 days after the injury. That's pretty quick. Those that returned, 30% had a recurrence but could finish the season. 33% had a recurrence and could not finish the season. So 66% of the patients who had the instability episode were able to return and continue to compete that year. Athletes with subluxation had a 5.3 times more likely return to play percentage than those who had a dislocation, and they returned sooner, which is what you expect. How were they treated? The rehab protocol, all patients really underwent an accelerated rehabilitation protocol. No patient was immobilized except for the first couple of days for the acute pain they had. And phase 1 focused on obtaining a range of motion. Phase 2 began periscapular strengthening and resistance exercises, and when a patient had close to protective strength, so 90% of the strength of the arm, he was allowed to return to play. Their criteria for return to sport: asymptomatic with all rehab exercises or mild pain, symmetric and full strength or close to full strength, able to return to sport-specific exercises. So certainly if you're a starting quarterback and you can't throw the ball, you're not going to probably go back in because you can't return to that sport-specific exercise. But a defensive back or a running back can return. And if they have no pain or minimum pain with their range of motion, they're allowed to return. McCarty did the same thing, looking at the ideal criteria for return to play. He described little or no pain, patient having near normal range of motion, near normal strength, normal functional ability, and normal sport-specific skills. And what's important here is actually, as a specialist, understanding the sport itself. So we had a captain of our team this year, starting running back, dislocated his shoulder. When he was a freshman, he had dislocated his other shoulder. I had fixed it. He's a captain team. Second game of the season, he dislocates his shoulder. We moved him from tailback to fullback, where he could still run with the ball, and he was told to run with two hands on the ball. So he puts his hand in position where he no longer puts himself at risk of dislocation. Now, understanding the sport is an important aspect of that. He's actually leading the team in rushing. He's got about 1,000 yards. The team's going to the sectional finals this week, and he's probably the most significant reason. But more importantly, he's now scouted and is going to go to college on an athletic scholarship. So you've impacted his life in a positive fashion. Is there some risk involved in playing? Yes, there is. But if the parents understand the risk and the kid understands the risk, I think you can make these decisions as a sports medicine specialist to allow them to return to play. Now, what about the role of a brace? There's a bunch of different braces, a Sully, a Sawa brace. All these braces do is control abduction, external rotation, so you can't put your hand in that position. You were more likely to dislocate your shoulder. Well, that's what we were doing with fullback, running with the ball with two hands. And actually, I was covering a game, and he broke free, and he started, giving the Heisman Trophy pose and putting his arm out. And I went over to him after he scored his touchdown. I said, "Great touchdown, but if I see you carrying the ball with one hand, you're not going to play the rest of the game." And the coach looked at me like, "What are you telling him?" I said, That's not a coaching decision. That's a doctor's decision. Don't put yourself at risk." So he's now running for touchdowns with two hands on the ball. Looks a little bit odd, but he's still scoring them. So the role of a brace. Does a brace work? Well, there's no evidence that says a brace really does work. The patients report they feel more stable. And part of this is the confidence of the patient themselves. So in my opinion, if they feel more stable, they're reporting they're more stable, it is working. Now, what's the risk of treating these patients operative versus non-operative? We say if we don't operate them, they have a 35 to 40% chance of redislocation depending on the age of the patient. If you do an arthroscopic stabilization, you can reduce that somewhere between 4 and 10%. And newer techniques are developing all the time, which allows us to be even better at this. Now, Lyle Kane is in the office, in the audience here, and Lyle Kane did one of the more famous shoulder operations in football with Jim Andrews on this guy named Drew Bledsoe, who was a quarterback who's made the Pro Bowl several times, and he had around the horn 360-degree instability. So people say you shouldn't do it arthroscopically, you should do it arthroscopically. With the proper technique, you can. I'll tell them my story. In 1992, the doctor for the New York Jets, and Glenn Foley was our starting quarterback, dislocated his shoulder, and I operated on him and fixed it arthroscopically. And it was the first arthroscopic stabilization in a quarterback done in the NFL. So I presented at the NFL team physicians meeting, and I was berated. I was like, "What are you thinking, doing that arthroscopically? Are you nuts? That's never going to happen. Never going to work." So Dr. Bergfeld was in the audience at the time, and he got up and he said, "Let me ask you a question here. How many of you guys fixed this open in a quarterback?" And a bunch of people raised their hand. "And how many of those quarterbacks came back?" And nobody raised their hand. And so Dr. Bergfeld, stop picking on the guy. He's trying something new because you guys haven't done anything right the last 50 years. So, sometimes we have to think outside the box. And with Lyle doing this on quarterback with the New Orleans Saints, he changed this guy's career. He's made the Pro Bowl 10 times, had a productive career. So again, let's think outside the box when we're treating these athletes. Immobilization, should we be immobilizing, and how long does it affect occurrence? There's no study that says immobilization affects the recurrence. So now let's go to the criteria if you do operate on them. Surgical management can be done in many different ways. We talked about arthroscopic, open techniques. There's newer techniques throughout and around. Most importantly thing you want to do is fix the Bankart. We can do it surgically now through arthroscopic techniques. Historically, the gold standard, Mike Pagnani's study looking at NFL football players who underwent a shoulder open capsular shift is the gold standard with only 1 to 2% recurrence rate in those patients. But the arthroscopic techniques have become more significant, as I've said, with Lyle doing that operation. Suture anchors and the advent of newer techniques has become a very effective way to fix the shoulder. So this is just a good example of a bony Bankart lesion that we were managing in his shoulder. What we do is we kind of mobilize the ligament, make sure the ligament is taken off so we can get a nice, good bleeding bony bed here. We're going to take the ligament, shift it back up, and try and save that bone so we don't have this defect. You can see the bone defect up top here can be quite significant. So the ways to do this are arthroscopically or open. In this particular instance, we decided to kind of drape our anchors over the top of the bone and get the bone to heal. This is a college wide receiver who we were doing this on. He came back, played 6 months later, and had a 3-year career at Hofstra University, and then subsequently went and played for the Denver Broncos. The unfortunate part about this was we fixed his shoulder. The following year, he came out with a little wrist fracture during a game. We said, well, you can play with the wrist fracture. We kind of put a splint on, put him back in at halftime, went back in. It was a minimally displaced fracture. Went in at halftime, had 2 touchdowns, and then tore his ACL. So we put him back in with a wrist fracture. He ended up tearing his ACL, so he's had shoulder fixed, ACL fixed, and the wrist fracture was treated non-operatively, but he ended up playing 6 years for the Denver Broncos after this. But you can see here, what we're just trying to do is pass sutures, allow those sutures to kind of stabilize the joint, and put the ligament and bone back to where it came from. Hot topic now, Latarjet procedure. You know, in the United States, we don't do as much as in Europe. In Europe, it's like eating breakfast. You come to a doctor with shoulder instability, they do a Latarjet operation. What that is, an operation where we take the coracoid and we cut the coracoid, flip it, and attach it to the very front portion of the shoulder. So in Pascal Boileau's work, who was saying these patients who had instability and a score of higher 6, he would then recommend patients undergo immediately a Latarjet procedure. There are really 2 viewpoints in this. There's the English-speaking world, which we actually can do an open capsular shift or other procedures, and we don't go right to doing a Latarjet. And the French-speaking world, which is really used as a primary procedure, even in the absence of glenoid bone loss. They'll just take this and reattach it. It gives a bony buttress here. It prevents recurrent instability. But it's not an operation that's to be taken lightly. It's fraught with complications, and I think to do something that's primarily doesn't make much sense. So let's look at the healing rates. What are we doing with these patients? You know, we really don't know what we're doing with ACLs or with shoulders because we don't know enough about the healing rates. And when we do know about the healing rates, such as an ACL, it says wait 12 to 18 months for the ligamentization to occur. So what do? We put them back at 6 months. So like I said, we're actually worried about the other parts of the body and trying to train those to prevent this ligament from seeing the trauma, the forces. Same thing with the shoulder. There are 2 studies in the literature looking at shoulder and labral healing that we see. One is a single monkey labral injury study where they sacrificed a monkey after 8 weeks of creating a labral tear and looked at the healing rates, but it's only 1 monkey. It wasn't a very extensive study. The other is a rabbit model where they did a Bankart and a biomechanical evaluation of a Bankart that was created and sacrificed the rabbits at 1, 2, 3, 4, and 5 weeks and looked at the histology and mechanical properties. What they did here was they created labral lesions here in the rabbit. They pulled on a lesion to see whether normal strength was obtained, and they did histological and biomechanical studies. The findings were that this histological healing process occurred at 3 weeks, and biomechanically the tensile load gradually increased to about 4 weeks. So the conclusion was it takes about 4 weeks to get a labral tissue to heal, which is fine if you have a rabbit playing in the NFL, but there are not many rabbits that I know about. So we really don't know what the return to play is as far as being guided by biology. So we basically are saying now 4 to 6 months biology, we believe labral healing occurs. We've extrapolated it from some of the rotator cuff data that's out there, but most of that return to play guideline occurs with the trainers and the therapists. Get these patients in a rehabilitation program and get them back to normal activity. So basically, we're pretty aggressive with our capsular repairs. We immobilize them for a period of 3 to 4 weeks, but we start mobilization exercises right away. At 4 to 8 weeks, we believe these patients get low-level isometric exercise program. And at 8 to 12 weeks, we focus on full range of motion and progressive resistive exercises. And the earliest I would allow one of my players to return to play is 4 months, but I tell them in general 6 months for contact sports, particularly for our hockey players who have our highest failure rates. So let's look at the return to play rates after having a surgery in the NCAA. This is done by Rich Robbins. He looked at return to play rates. 85% of football players return to play 6 to 9 months after having an arthroscopic or open capsular shift. No difference whether it's an arthroscopic or open shift regards the ability to return to play. And many of those players, 85%, were able to return to the same or higher levels. In the NFL, 60 players underwent shoulder stabilization surgery, 54 returned to play. Average return was 8.6 months. Conclusion was return to play was very likely after shoulder surgery. So we see in the data here, shoulder non-operative versus operative treatment. Operative treatment, 14% recurrence rate, non-operative 80%, 94% versus 4%, 75% versus 11%. And in general in the literature, you can say non-operative recurrence, operative recurrence rates in the high-level athlete, somewhere between 4 and 10%, and in the patients who are not operated on, recurrence rates somewhere between 75 and 80%. So it advocates doing these surgeries. How about return to sports for overhead activities? You could say here somewhere between 85 to 90% of these patients return to sports for overhead activities. So in summary, glenoid instability is a challenge for the athlete and the sports medicine team. We have to think outside the box when dealing with them. Majority of athletes, when treated non-operatively, are able to return to play within 2 weeks. The return to play is variable depending on many factors, including position and whether they're throwing athlete or not. There's some ideal criteria we want. We want protective strength with these patients. More research is needed to understand the biology of these patients and whether or not the labral healing occurs and to what degree it occurs and at what time it occurs. Most of these patients who have this injury lead to surgery. When we tell them to go back in the game and tell them to go back for the season, we tell them the deal is after the season you're going to need it fixed. Many people say, I played the whole season, I had no problem with it. Then they come back and play the next year, they're going to lose another season. So we try and tell them the deal is when we fix them, when we allow them to go back in, we're going to have them fixing it after the season. And if you tell them at the very start, most players have no problem with it. So understanding it's biology versus the patient. Patient wants to go in right away. The biology says they shouldn't. When we let them go in non-operatively, the biology says they absolutely shouldn't go back in. But we try and create a situation where they have protective strength, allow them to play, roll the dice a little bit, allow them to return to play, finish their season if it's a senior year or some extenuating circumstance, and fix them afterwards. So thank you very much for having me. Any questions you might have? Lyle, I'd like you to just, before we go, just tell me your approach to the in-season athlete, college, professional, and also high school.
Thanks, Steve. That's a great talk. I think it depends on a lot of factors, and so I think what we do in medicine with most of the things we deal with, whether it's a hand injury or shoulder injury, it's all a risk-benefit analysis. So you've got risk on one side, you've got benefit on the other, and you have to kind of factor those things in when you decide whether somebody plays with this. I certainly believe that most players in most sports can play with an unstable shoulder, with protection. So, if they're a quarterback and it's a dominant arm, probably not going to work. If they're an offensive lineman and it's their dominant arm, they can probably be braced and protected. So a lot of it depends on their position and what their goals are. If they're a senior, I certainly let them play. If they're a high school kid that's really gung-ho, I'll let them play. But if they're apprehensive at all, if their parents are apprehensive, or if they're in a position where I think that it's unlikely that they'll succeed, I start laying crepe early and try to get them prepared for surgery, and I always fix these. So, in a young athlete that has an unstable shoulder, even if it's a one-time dislocator, I always fix them in the off-season or whenever that opportunity occurs, because I think you really cut down the re-injury rate by doing the surgery to fix them.
Excellent. Any other questions?
I have a question.
Yes, sir.
First time dislocator. Kevin Wilk talked about ACL Coopers. is there a shoulder dislocation coper, and how would we identify them?
Well, 30% of shoulder dislocations don't redislocate. So they're obviously coping in some mechanism. Most of it, I think, is because they monitor their activities. So I don't think we've defined a true coper in that way. I think the best bet to fix a shoulder and to do it well and right is you do it right away, because it's like a jigsaw puzzle. You can see where things came from, and you can put them back to where they belong. Doing it at a later stage, your success rates reduce quite a bit. Lyle?
I agree.